Mike Gibson, Jim Januzzi, reporting to you from AHA 2025. Jim, you presented some interesting findings looking at the triangulation of amyloidosis, atrial fibrillation, and BNP. Talk to us a little bit about what you found.
Sure. Yeah. Thanks, Mike. It's great to speak with you. One question that comes up clinically in the care of people who have amyloidosis is we know that NT-proBNP and BNP are prognostic, but we also know that atrial fibrillation is very common in these people, and there's a described interaction between atrial fibrillation that causes higher BNP levels. And so the question is, does treatment with acoramidis, which we know can potentially reduce atrial fibrillation episodes, exert the same benefits in people who have AFib relative to their biomarker patterns?
Now, Jim, do we know the directionality of that? You said AFib causes BNP to go up, but could it be that the the LV is hardened, the left atrium stretches, and it really is that the pathophysiology? The BNP is high because the amyloid is extensive?
Exactly. Is it a true positive or is it a false positive because of the AFib? And furthermore, can we trust the prognostic meaning of natriuretic peptides in atrial fibrillation among people with amyloid?
Yeah, so what do you find?
Yeah, so the good news is that acoramidis has similar benefits in terms of reducing event rates in people with amyloid, despite the presence or absence of AFib. And the patterns of natriuretic peptide do, in fact, allow us to prognosticate regardless of the presence of atrial fibrillation, which affects a substantial percentage of our patients with amyloid.
So educate me, Jim. During the trial, did the BNP go down over time? I mean, was there regression of the BNP in the acoramidis group?
Yeah, so we are currently working on these analyses presently at the BAME Institute for Clinical Research. But what I can tell you is that in the original baseline manuscript published in the New England Journal of Medicine, the investigators did report that NT-proBNP concentrations over time are lower among individuals treated with acoramidis versus placebo, which really suggests a stabilization of the disease.
Stabilization, but what I was really driving at, Jim, was is it actually regression of the disease? You know, I know they've done some imaging studies. It'd be interesting to look at the imaging versus BNP to see if regression of disease is associated with lower BNP, which I bet it would be.
Yeah. So there are emerging data. The time horizon for the Attribute clinical trial was 30 months. And there is evidence that there are some patients who indeed show a reduction in NT-proBNP. The question will be whether those reductions correlate to improved outcomes. And of course, as you're implying, a physiologic change. And Attribute didn't do imaging, so we can't speak to that, but there are data looking at the impact of stabilizers and other therapies for amyloid on disease regression, which are looking very promising.
Anything else coming along in the future, Jim?
Yeah, well, we're also in our studies at the BAME Institute, Mike, we're looking at concentrations of transthyretin, right, which is thought to be a pathophysiologic player in the genesis of amyloidosis through the misfolding of the protein and generation of these sort of toxic fibrils that lead to amyloid deposition and cardiac injury. What's interesting is in the Attribute study, changes in transthyretin were also prognostic. And so now we're examining the really interesting interplay between the transthyretin levels and NT-proBNP levels. And suffice to say, we've got some exciting data that we're looking forward to sharing in the very near future.
Well, that could be tough to sort out. I mean, if they're related to each other, they could be colliders and models and things. Fascinating work, Jim. Thanks for moving the field forward. And thanks to all of you for joining us here from AHA 2025.